Okay, looks like, oh wait, let me just let this last person in. But thanks to everyone for joining us today for the Emergency Medicine Bootcamp. I'm Jerry, I'm one of the National APAMSA alumni directors. And with us, we have four residents and attending here to just volunteer their time and share a few all these pearls of knowledge.
So welcome to EM Bootcamp. We're a group of Asian Americans who really are just going to share our experiences in emergency medicine over the past few years. The conversation will mostly be focused on rising interns and rising sub-Is, but there'll be some time at the end of the conversation for really any questions that all of y'all have. So basically the structure of today is we'll start off by each introducing ourselves and kind of our own background. Afterwards, we'll go into some common chief complaints in the field of emergency medicine, and then we'll transition into talking about really just tips and tricks to managing the resuscitation room, which will mostly be appropriate from an intern perspective. Lastly, we'll spend some time talking about different organizations within emergency medicine itself before transitioning to some breakout rooms focused on the interns and sub-interns, where we'll first answer some pre-submitted questions before going into any questions that you'll have that come up through this presentation. Lastly, I think Jerry just sent this out via the chat, but please put any questions into the chat, and either one of the physicians or one of us, that's a little weird and we're calling ourselves physicians, but one of us will answer the questions in the chat, or Jerry, if you could just bring it up if no one answers it throughout our conversation. So without further ado, we'll start with some introductions.
Hey, my name's Gary. I'm YA attending now. I'm practicing in Los Angeles, California. I'm originally from Providence, Rhode Island. Grew up, my family's from Laos, so first generation here. Went to Providence College, went to Brown for med school. I did residency in Pittsburgh at Allegheny General Hospital. So far, I worked at Jefferson Hospital and Allegheny Valley Hospital in Pittsburgh, and now I'm currently at Valley Presbyterian Hospital and Encino Hospital in LA. So I work mostly in the community. I do a little bit of teaching here and there for like PA students and stuff. Try to do some academic work. And outside of work, I do soccer, I do video games, basketball, photography. I cook a lot. Follow me on Instagram to see all my food stuff. And I like to eat and just like hanging out, vibes. I would have 2 cats. One would show here. So I miss you.
Hi, everybody. Can you hear me on my?
Yeah, we can.
Sweet. Hi, everyone. That is a photo recently of me going on a flight ride along for my EMS week. So I hope that gets you psyched about EM for sure. I'm originally from a suburb of Philadelphia. Also with me, I have some classic EM things, Red Bull, a beer, and my bike helmet, despite the fact that my bike got stolen like a year ago. I trained up in Boston, and then I overlapped with Gary for a year or 2 at Brown, and now currently back at Philly at Temple, really close to my mom. So she's going to come over later today. I think it's really great to have family near you. Like, she just brings me food, she waters my plants, sometimes does my laundry. It's amazing. I studied anthropology in undergrad as well as global health. Anyone who's thinking about EM but not sure, that's totally fine. I officially decided to apply into EM a month before applying. That being said, it was during COVID, so I think I did about 12 shifts and was like, yeah, I guess this is going to be my life. And then I'm really interested in ultrasound and austere medicine and global health. Outside of work, I love trying new hobbies. There's this recent like TikTok trend that was like, I like to do this and that. That's like totally me. I just like try new hobbies. I'm not good at any of them. So recently I've been playing a lot of tennis, tried scuba diving in Monterey for the first time, and ordered my first pair of roller skating, and I want to do that in the summer. I'll pass it on.
Awesome. Thanks, Vivian. And I will be joining you on that roller skating adventure because I also got roller skates. Yay. So hi, everybody. My name is Wendy. I'm one of the third-year residents at Yale, and I'm also one of the incoming chief residents as well. I grew up in Toronto, Ontario, did my undergrad at Columbia, where I studied biomedical engineering, and then went to Virginia and Commonwealth University for medical school. So kind of outside my clinical duties, I've been so fortunate to be the president of SAEM RAMS, which is the Society for Academic Emergency Medicine Residents and Medical Students. And actually, SAEM is right around the corner. It's next week. And so that will mark the end of my presidency. And next year, I will be stepping in as the SAEM Board of Director role. And I'm just so excited to be here. You guys definitely chose the right specialty. And so for me, outside of work, I love skating. So over the summer, I'm planning on roller skating. I'm excited that the weather is warming up to go paddle boarding. I love exploring, love playing team sports. If there are any spike ballers out there in the New Haven area, hit me up. Always like to spike ball and love quality time with family and friends as well. So with that, I'm going to pass it on to David.
Hey guys, my name is David. I'm a second-gen Chinese American kid who grew up in New Orleans. So if you guys are going to SAEM, the last time it was in New Orleans was actually my first introduction into emergency medicine. So I heavily encourage y'all to go to these conferences. I went to undergrad at WashU in St. Louis and did a bunch of engineering stuff, and then went back to New Orleans for medical school. And now I'm a co-resident of Wendy's, and my focus is, outside of all the clinical stuff we do, is mostly on research. So I focus a lot on disaggregating Asian American mental health issues. So if any of y'all have any interest in that type of stuff, feel free to contact me. And then I'm also running this kind of a long-term study on basically how Asian American medical students look at discrimination as a medical student. So let me know if you're interested in that as well. Outside of work, my kind of, I guess, three big things are, I really like trying new restaurants and bubble tea stuff. I do a lot of martial arts. So New Orleans doesn't have any, but the New Haven area actually has a bunch. So I do that basically every single day. And then I also spend time with my wife and my cat too. So that sometimes happens. Pass it along to Max.
Hello, I'm Max. I am a second-year resident, also at Yale. I grew up in Busan in Korea, and then I lived in England for a while, which is why I went to undergrad in Cambridge, and then came over here because I actually was born in Michigan, but had no memory of it because I had only lived there for a couple of years. So I came over here, see what the fuss is about. Went to UPenn for my postbac program, and then Cincinnati for med school, and now at Yale. I think the only thing I thought was kind of relevant in terms of career path for me is just the fact that I nearly went into surgery. So if there are like rising MS4s who are kind of still having some questions about that, feel free to ask me any questions. Outside of work, I'm not a very active, like physically active person like a lot of the other people are. So I'm more of a food, desserts kind of person. I have a lot of plants. And do some art and music. I just got a piano, which is very cool. And I hope to have a dog one day, so I can list that as one of my outside of work interests.
So just briefly before we transition to talking about emergency medicine, if any of you guys have questions, we've already mentioned this, just put it into the chat and the people who aren't talking will answer. And then if any of the audience members who are here today want to answer any questions, just be sure to mention your name, the school, and the year of training, just for basically reference. And we have a little side panel of what that looks like for those of you who have never used Zoom before. Okay, next slide. So just really briefly, I know that you're all thinking, should I go into emergency medicine? Or, wow, I really want to go into emergency medicine. What do I do? I just want to talk really broadly and then invite you guys to answer just one question in the chat. So really broadly speaking about emergency medicine, there's a lot of really great things about it. And then there's also things that you should heavily consider when thinking about your future lifestyle. So this is mostly a super rewarding specialty, but it's important to recognize there's a lot of difficult challenges within our specialty. We really focus a lot on a team-based approach. So I talk to the nursing staff, the tech staff, the attendings, the consultants regularly throughout all the shifts. And I know most of them on a first name basis because we work so closely together. And a lot of our care management plans are very team-based approach. So if I'm saying something, but a nurse or a tech disagrees, like I want them to basically have that conversation, be comfortable having those conversations with me. And that's really just a focus on camaraderie, both in the hospital, but also hanging out with them outside the hospital. Another big thing is recently emergency medicine has really turned their attention towards community. So this is the community, not just within the emergency department, but also the community of basically the encashment area that we treat. So here, for example, in New Haven, we treat patients in the emergency department, but there's a lot of interest towards like, how do we help our patients outside the hospital in the community? This is thinking about like how to manage opiate use disorder in the long term, how to help our patients, not just with their medical problems, but with also their socio-legal problems. So that's another big area that's growing. That's really that I've at least witnessed since my first year of medical school. And then the last thing I'll mention, because it's a hot topic in terms of conversation here in emergency medicine, but also the global conversations about physicians in general, is burnout. A lot of people say that burnout is really high in emergency medicine. And I think that COVID has only exacerbated that for all specialties. My only comment there is that, yes, it's a tough specialty, but really that camaraderie and team that we build, I think really helps prevent burnout. And there's a lot of strategies that I'm happy to share in the breakout sessions, specifically about how I mitigate burnout. And I'm sure the other people here also have their own approaches. So just as one question, put it into the chat. Why are you joining emergency medicine? Or if you're not really sure right now, like, why are you thinking about joining emergency medicine? I'm gonna give you all a couple seconds to respond. I know this is Zoom, so while you guys think about this, I joined emergency medicine because in my very first year, I went and was a medical student ambassador to SAEM in New Orleans. And I literally tweeted at this like big hotshot doc who was at the conference. And they set aside time for us to chat, like at a Starbucks in the hotel. And that really has set kind of really strong expectations that have, I think the field has really met. People are very, very open to discussing things. And it's just this shared camaraderie that doesn't just focus on the emergency department itself, but also in the national perspective. I'm seeing that it is just so much fun. I totally agree. I love it. Okay. Not seeing a whole lot of participation, but that's okay. We'll just move on. Being the first detective, I love it. The undifferentiated patient is like the best thing ever. Personality, yeah, like I could definitely not be a surgeon. I don't understand Max's thoughts that she could be a surgeon, but that's where it is. Yeah, the community health focus is such a big, big topic. I love it. And we'll go into that a lot more. And thank you guys so much for going into this. We'll just transition now to the chief complaint section. So just as a brief overview, we'll be talking about some common chief complaints. We'll do a quick break, and then we'll go into tips and trips related to the resuscitation room itself. Afterwards, as Wendy mentioned, we'll go into, or sorry, I mentioned earlier, Wendy will be going into a broader discussion on emergency medicine. Okay. So this is just my one comment before we can go into the chief complaints. This is my own perspective on every single patient I see, is what do I want to know or think about before I walk into the room? And then what do I want to think about and know, or at least take the first steps towards knowing as I leave the room. So as I walk into the room, what do I need to make sure it's not? Do they look sick? What are some immediate pieces of information to know? So do I want to ultrasound them as I'm talking to them? Because will that make like a clear difference in my management, as one example? And then as I leave the room, what's the most immediate next step that I need to do? What things do I need to order and why? Do I need to call anyone? And as I walk out of the room, do I already know if this person's going to be admitted? Or do I know or think that I can probably get this patient home? And then the last thing is, are there any rate limiting steps, things that I can do to help disposition these patients? Okay, and next.
All right, so this is me. I'll be your first chief complaint. And of course, we got to start with chest pain because that's like classic EM right here. Okay, so I want everyone to be, you know, as like message in the chat box, like what do you think this picture is? Who is it? What am I trying to get at? I want everyone to be engaged. This is like EM. I wish we were in a room, you could shout it out. It's a blank sign. Do we know? Okay, great, Cindy. So it's the Levine sign. It's great that I could find Levine doing the Levine sign. So it's the person that's being rolled past you by EMS going like, oh, and then as an intern or an MS4, you should just follow them into the room. You should just go with them and like ask EMS, be like, hey, what do we have? What's going on? Grab a nurse, get an EKG. So this is a classic thing. Okay, so walking in the room, what do you do? All right, first things first, anytime you walk into a room, you cannot assume that they're alive, okay? Do not be surprised. In any specialty that you go into, this will happen to you sometime. You'll go in, you'll think they're asleep, and then all of a sudden we're like running in a backboard, so we're starting CPR. So you never assume they're alive. If they're not breathing and you feel for a pulse, start CPR yourself. Put down the railing, like get to know the hospital bed. Put the railing down. If you're 5'1" like me, I jump onto the bed and perform high quality CPR because that's the only thing that is proven to extend, like have good outcomes, like not epi, nothing else. Okay, CPR and call for help. You're like, you know, you're gonna be great. Second, if they're not dead, you're gonna go in and see, oh, are they sick or not? And you're gonna get a good gestalt. Like someone's gonna be like, oh my gosh, or like they're just chilling. You're gonna get a better understanding of that in the future, but this is good. Just ask yourself, like, do I think I need to call my attending or my senior right now? Or do you think I can proceed with like, give like a couple 5 minutes? So how are you gonna figure that out? You're gonna look at them, you're gonna look at their vitals, very important. If there are no vitals, this is a perfect time for yourself to put on vitals. So this is you knowing where the pulse ox is, knowing where to put the EKG leads on, putting the blood pressure, right? If they're sick, go to the monitor, they don't have it, and then determine, and then also get the EKG for the chest pain. And a lot of EDs already like have people get an EKG right at the door. So that should be in the chart as well. So this is like what you should be thinking of every time. And even now as an intern, like I'm thinking you can like go through all of them. Let me These are the ones I'm walking through. I have dot phrases in the beginning when I want to make sure I ask the right questions, to make sure that I thought through everything and have a reason why I don't think it's X, Y, and Z. So first off, like ACS, acute coronary syndrome, or your classic heart attack, you're going to look at your EKG, and you're going to practice EKGs, look at STEMIs, look at STEMI equivalents. If you think it is, go ahead, give the aspirin. The EMS is already probably getting the aspirin. You're gonna ask yourself, oh, should I get a troponin or not? There are scores for this. This is obviously something we always think about, right? But I have a lot of ultrasound photos in here as well. Just like David said, right? Do you bring the ultrasound in while you're at it? And it's okay if you start intern year and you've had no ultrasound experience. I was so bad at the ultrasound, like really bad. Like someone asked me, do they have cardiac activity? I was like, oh, where should I point the probe marker? They're like, it doesn't matter. Just like aim at the heart. Like, is it moving or not? Like, so it's okay. Start getting your feet wet. Like EM is like such a big leader in POCUS, like bedside ultrasound. So you're going to be able to see tamponade, which is, you're going to be seeing fluid around the heart. You're going to be able to see if there's a hint of a dissection looking at the aortic root. And then you're going to ask yourself, do we need to go straight to CTA? Am I really concerned about dissection? For pulmonary embolism, you can see if there are signs of right heart strain on the ultrasound as well, and decide if you need a D-dimer or also a CTA. And this is a good discussion, because sometimes you're not sure if there's pulmonary embolism or dissection. And you need to think about like, which CTA am I getting? So like, this is why ultrasound is great. And you're usually going to get a chest x-ray as well. And you'll be able to see tension, pneumo. Oh, and also for the pneumothorax, you can look for lung sliding. So many things in the chest pain differential can be done through the ultrasound. And then smaller things like esophageal rupture. There's a bunch of other kind of like not big things that are like good to know. Like if they're like vomiting a lot or like coughing a lot, or they had a recent procedure done and you can see like air within like the mediastinum. So yeah, like Gary mentioned, I didn't know how much time do I have left to try and make it short. Do you have time? There are like big scores that you can use, like Gary is saying, the heart score for whether or not someone can go home or needs to come into the hospital to be observed for a possible heart attack, and then PERC and Wells for the pulmonary embolism. And your ED might also have a protocol for like getting the D-dimer and things like that. So it's, you're gonna have, like, I feel like at my hospital, every year we always have an M&M or morbidity and mortality conference on a PE that we didn't find. So I feel like you're going to spend so much of your career wondering when to get the D-dimer. So don't worry if that's something that like you're still struggling with, because I am still struggling with that. So I'm going to pass it off for arrhythmias.
Great. So for arrhythmias, this could actually be a lecture in its own. So in the 5 minutes that we have today, I'm going to be talking about just kind of brief highlights that you should have in the back of your mind. So whenever there's a patient who has an arrhythmia, who comes into the emergency department, Vivian kind of touched base on this already. So you think to yourself, is this patient stable or unstable? Unstable meaning, is their heart, because of the arrhythmia, is it pumping enough blood to their, to the organs like their brain? Like, are they walking, talking to you? What's their blood pressure like? Is their, mean arterial pressure less than 65? And, what are the rest of the vital signs? How is the patient looking like? And so when you have an unstable patient, and even when you have a stable patient who you anticipate could become unstable, everyone emergency in medicine loves to be prepared. So just put the pads on for good luck, good energy, and get the patient on the monitors. And your nurses are usually on it. Get 2 large bore IVs in case you need to push any medications. So after you determined if a patient is stable or unstable, kind of the next 2 big categories I have in my mind is, what's your rate? Is your rate fast or slower than normal? So kind of going, starting off with slow, if you have an unstable patient, someone with a heart rate, let's say in the 30s, 20s, and they're not talking to you, definitely check for a pulse. If they're not talking to you and they don't have a pulse, then you start CPR and go down your algorithm. If it's someone who's like very symptomatic from their bradycardia, like they're in the 30s, maybe like mildly hypotensive, but they do have a pulse, you should start initiating transcutaneous pacing. And how that usually works is, you start off at 70 milliamps and you begin to go up in your milliamps until you have electrical capture. And this is one of the key points. Once you have electrical capture, where you see that the Zoll has paced and you see it on the monitor, check a pulse to make sure that you have mechanical capture as well, because oftentimes when you have electrical capture, you might not have mechanical capture yet. And so it's really important to ensure that the electricity you're delivering is actually causing the heart to move the blood forward in the body. And so usually once you find a milliamps that is appropriate for the patient, you like to set it 5 to 10 milliamps above that threshold. And so if transcutaneous pacing isn't working because, let's say the patient's super diaphoretic, the pads aren't sticking to them despite every attempt to hold the pad, get the pads sticking again, or because of body habitus, then, you think about your transvenous pacing. And oftentimes, there could be stable patients with heart rates in the 30s. I've definitely had patients who have rolled into the R room with a heart rate in the 30s and 40s, pads are on already, but they're talking to me. Their blood pressure, is normal, like 120s over 80s. In that case, then you call your EP cardiologist and then you admit the patient for a pacemaker. You still keep the pads on just in case they become unstable, but just because, someone has a heart rate in the 30s, 40s, doesn't mean that they have to get paced, because as patients will tell you, it's very uncomfortable to get shocks every 70 times a minute. And then so with your fast rhythms, again, you're thinking about stable, unstable. As you know, like with the ACLS pathway, with, ventricular fibrillation, ventricular tachycardia, the answer is, you should deliver electricity. And I think one key point here, because you have different types of fast rhythms, you need to be able to distinguish, is this a rhythm that needs to be defibrillated for an unstable patient or cardioverted? And so the key point here is with cardioversion, the monitor is actually delivering the shock at the appropriate time, meaning not during when the heart is repolarizing, because delivering a shock when the heart is repolarizing can precipitate someone, let's say they're in SVT and they're unstable. If you defibrillate them instead of cardiovert them, you can actually precipitate ventricular fibrillation. But let's say, your patient in this case is stable. They're talking to you. They're just saying, oh yeah, I feel my heart is going very fast. Then you could, if that's a patient that you have in the resuscitation room, it's important, to get an EKG, look to see what the rhythm is. And based on the different types of rhythm, for example, VTAC, you can try amiodarone, SVT, adenosine, AFib with RVR, metoprolol-diltiazem. You could, you have time to think about which medication to give and really take a look at your EKG. But again, if the patient is unstable, electricity is really key. And if, they don't have a pulse, and if, let's say they're in VFib, you give them a shock and then you start CPR. And so those are really the key highlights, being able to distinguish stable, unstable patients, understanding cardioversion, defibrillation, and understanding kind of the transcutaneous pacing, that there's electrical and mechanical capture as well. And with that, that should kind of help you for patients who come in with arrhythmias. And so with that, I'm going to pass it on to Gary, who will be talking about abdominal pain.
This is another wonderful complaint that we get from our patients that come to the ER. So, abdominal pain is a pretty common one. So the different, you'll really have to work through your different differentials, and you have to try to see a lot of it is clinical gestalt, reevaluating and seeing what exactly is going on with the patient to kind of make your dispo. So really important, and this is important for your boards and everything too, is that when you go in, you got to think about it. What you see is always the first question you ask on your board, on your oral boards too. Is like when you walk in, like what do I see, smell, and hear when I walk in the room? And that's the same you should do every time in real life too. So when you go see your patients, like what do they look like? To quote one of my, do they look like a dish rag? To quote one of my attendings, do they look like they're supine? Do they have the crossed leg sign where they're just sitting there with their legs crossed and they're like, oh, my stomach hurts? Or or are they like rolling over on the side of their bed crying in pain? Also smell, like if you have ever smelled melena, you will never forget it, and it is a smell that you will always remember. Or and I guess another thing too is like location, like where is this person in pain? You should try to divide the abdomen into quadrants and work on your differentials based on that, because that's really helpful in determining like what kind of pathology they have, like where, like is it like in the right upper quadrant, is it right lower quadrant? Also, is it migratory? Like does it go from the periumbilical to the right lower quadrant? Does it still from the right flank into their groin? Is it in their testicles? It goes to their goes into the rest of their abdomen? Is it in their or is it somewhere else, or is it like somewhere, or stuff going from somewhere else going into another area? So that's also very big. Those are big important questions you should ask as well. And also just check for what other symptoms they have. Because you can always check to see like, are they having nausea? Are they having dysuria, hematuria, having vaginal discharge? Are they having chest pain? Do they have numbness? Do they have numbness in their lower extremities? These are all things you should always consider too. And also the other question you should always have in the back of your mind is this really abdominal pain or just something else going on? Because they can be complaining of right upper quadrant pain, and then you could see that they have, could they have an pneumonia? Could they have a PE that's causing irritation? Do they have epigastric pain? And then that's that, like they're, a 68-year-old saying I'm having an MI. Are they children? Are they having testicular pain? They're saying it's abdominal pain. These are all things that you should consider going into your differential, especially when you for all these patients. And again, the type of pain, like is it a burning pain? Is it a sharp stabbing pain? Is it just a colicky pain? All these are all just kind of like basic. These are all important basic things that really help your differential and will help you in when you present your attendings as well. This is kind of just like a quick thing I stole off the internet, kind of showing you what to worry about. Like I said, epigastric pain, always consider MI, especially in your older people. Is it pancreatitis? Periumbilical pain? Is it appendicitis? Is it again like an aortic dissection? Is it AAA? Flank pain, renal colic, pyelonephritis, could also be PID as well. Right lower quadrant pain, obviously we don't want to miss like appendicitis. You don't want to miss like renal colic as well. Left lower quadrant pain, you have like diverticulitis, you have like obstruction as well, and suprapubic pain. You have to consider your other differentials like UTIs, appendicitis, diverticulitis. Like those are it's kind of run through all the diagnoses of abdominal pain, but those are kind of like the highlights. So yeah. Your workup, always start with your labs. Always think about what you want to find when you order a lab. Don't just order labs because you can. Think of like, what am I looking for? Because everything that you order, you are responsible for, and you have to find a way to justify it in your note. So like, for example, sometimes there'll be 2 ways ordered that have blood in them, and then you have to explain why there's blood in it. So to get a CBC, CMP, always look for liver functions. Get a lipase as well if I have to add that. You can get a urinalysis as well. Kind of hit your big points and all those things. Ultrasounds, while you're training, they can be helpful. When you're training can be helpful. Right upper quadrant ultrasounds, also testicular ultrasound depending on your diagnoses, and CT scans. 65-year-olds, anyone above 65 I scan, no question asked. Old people lie all the time. Anyone, and they're like a rough 60, that I scan them as well. I don't really care about if I scan people or not anymore. I just scan them and also your clinical gestalt. Can also help with your CT scan, like if you have a weight count or something you can't explain. And the next slide, these are some can't miss diagnoses that you should always consider. Perforated ulcer, always do a chest x-ray. I've seen chest x-rays where you just see like huge amount of new perineum, cholecystitis, appendicitis, ruptured AAA. If they have a history of a AAA, you should always check with an ultrasound. 4 years gangrene is another big one that you should not miss, especially if you have a history of diabetes and ischemic colitis, pancreatitis, and also don't forget ovarian and testicular torsion as well.
All right, now I'm going to follow that up with GI bleeds. I think we skipped a couple. Perfect. All right. So GI bleeds in general. So first things to consider, number one is it actually a GI bleed that you're concerned about here? Or is it actually a hemoptysis? Is it large volume epistaxis or nosebleed that's draining to the back of the oropharynx, and then they're swallowing all the blood and then vomiting it back up? So is the source actually from the nose instead? Is it actually a vaginal bleed or even a urethral bleed? And then you also, people like to divide GI bleeds into uppers and lowers. Make sure you remember that a very brisk upper GI bleed can sometimes look like a lower GI bleed. This might not be as important if the patient is very sick. So you just have to kind of take care of the patient in front of you, but definitely important in trying to figure out how you can achieve source control. And then another way of dividing up GI bleeds is minor versus major. There's not really like a consensus on like the volume of bleeding or anything like that, but essentially this is the patient sick or not from the bleed? These are the first things that you want to look for in a patient who comes in with GI bleed anyway. So whether the hemodynamic is stable, are they protecting their airway, and is their mental status intact? Some of the differentials for any GI bleed, oh, sorry, can you go back? That you want to consider, Mallory virus is pretty common. Bull have, definitely less common. Variceal bleed can bleed a lot. Peptic ulcer disease is the most common cause of acute upper GI bleed in the US. One thing that I honestly haven't seen, but aortoenteric fistulas are something you also should consider, especially if the patient has had history of AAA repair. And then diverticulitis, some hemorrhoids, malignancy can also cause GI bleeds. And then if it's a minor bleed, essentially you're saying the bleed itself is not really the core problem here. The focus is more on figuring out what's actually causing the bleed so that you can prevent it from becoming a problem in the future. So a lot of the decisions will kind of be based on the specific patient you have in front of you, what they look like, how much bleeding it is, and what the comorbidities are. So a lot of it is weighing risks and benefits. So a lot of these are, as you can tell, consider all of these things. None of these are set in stone. So you can consider imaging. Remember the patient will be gone for a while in the CAT scanner lying flat. So make sure you reassess the airway and make sure they're going to be safe to get the imaging. Consider holding any anticoagulation if they are on any. Again, you have to outweigh the risks and benefits for this. Consider a GI consult or a referral, like as an outpatient setting, and perhaps an admission to make sure the bleeding doesn't get any worse. Glasgow Blatchford score is a scoring tool that can also help you in risk stratifying low risk GI bleed patients to figure out if they're candidates for discharging and following up outpatient, something for you to look into in the clinical years. And then for a massive GI bleed, so these are mostly due to upper GI bleeds. A lot of these will be patients with cirrhosis. So by definition, pretty much, they are going to be hemodynamically unstable. You will resuscitate them as you would any kind of hemorrhagic shock. So initially, some IV fluids is reasonable, but you need to obtain access, at least to large bowel access. Consider putting in a large central access like a cortisone. You can give a couple uncross-matched units to start with, as in red blood cells. But if that's not enough, you go on to starting massive transfusion protocol. And then everyone likes to talk about, like, if you do a massive transfusion protocol, excuse me, you want to do like a balanced transfusion. So red blood cells, platelets to FFP ratio should always be 1 to 1 to 1. If there are any anticoagulation, reverse it. Assess the airway. It depends on the mental status and the volume of hematemesis. Elevate the head of bed so they are kind of upright, so the gravity helps in protecting the airway. This is free, always do this. Give them antiemetics if they're throwing up blood and that's what's causing the issue. And then you may have to consider intubation. And obviously the goal is to achieve some source control in these patients. In upper GI bleeds, most cases, this will be an emergent GI consult. So pick up the phone or someone gets most likely call IR. In some cases, it might actually be surgery, but usually it's IR, and they may want to get imaging so that they can see exactly where they need to go in and embolize the area. And this will be a CT angio. For upper GI bleeds, you should also give adjunct therapies such as PPI, so Protonics IV. And then if you suspect variceal bleed, give them octreotide. If none of this is working and the patient is very, very, very sick in front of you and truly requires emergent source control, like right now, otherwise you think they might hemorrhage and code, that's what a Blakemore tube is for. And it's essentially a giant balloon that's going to go inside and then tampen out the stomach and esophagus from the inside. And then one last thing is ceftriaxone or Rocephin, it's the antibiotic. It is pretty much the only medication that's actually been proven to improve mortality in acute upper GI bleed patients with cirrhosis. So make sure you don't forget that.
All righty, how are we doing? Can I get a little thumbs up, whatever, from people who are still here? Hopefully you're still tracking with us. It's a lot so far. Okay. We'll send out the slides. You're going to spend your whole life hopefully doing this. So it's okay if you feel overwhelmed, right? If you take a couple things from this, you'll already be like really great. All right. So back pain. Well, when you see a patient that has back pain, you might start feeling back pain because it can be a very frustrating common complaint for people. Let's see, you can go to the next one. So back pain, the way you can ask other people how they approach it is like, what are the red flags? Again, like many complaints that I must not miss, because I defer usually to be like, oh, you got low back pain, you're fine, right? Like, and they're usually fine, but you gotta make sure you don't miss the like really bad stuff, right? So they could have an aneurysm again, right? Like something masking as another complaint. This could be cancer as a first presentation. Cauda-Equina syndrome, always something that people talk about. It could be an infection. It could be a fracture. These are only a couple like kind of do not miss big differentials. There are other things. So with these in mind, what are you going to ask when you go up to a patient with back pain who's like probably sitting in the chairs, not even in a real room? Next slide. So with these in mind, again, right? So what are you going to ask? Next slide. Yep. You can have a mnemonic. I just found this. This is good to, if whatever works for you. Okay. So you could, if someone like got hit in a car crash, or like older people who fall, even like they just fall into their tailbone, still could count. And if they have any midline tenderness, B signs, so like unexplained weight loss towards like the cancer concerns, any focal neurologic symptoms. So do due diligence and do a neuro exam quickly. Any age that's like kind of older or younger, like if you talk to any pediatric EM doc, like young people usually shouldn't have back pain and you should delve a little bit more into it. Conversely, older people, they always have something. If they have fevers, if they're IV drug user, a lot of folks in my community use that, and that can lead to infection. Like if you've heard of like epidural spinal abscess, like that's something that you should pause and just ask a little bit more about. Long-term steroid use, and a history of cancer, as all these, prostate, lung can go to the spine. So again, David shared one as well. So next. So there's going to be a lot of people who fall in this category of acute back pain, neck pain for less than 6 to 8 weeks without any red flags. So you've asked all your things, you've done a neuro exam, you don't find any of these red flags, right? You don't have to do X-ray imaging. What they need is an unsatisfying answer of multimodal pain control that includes lidocaine patches, that includes capsaicin creams, acupuncture, PT, NSAIDs, not muscle relaxants. I mean, if they're asking for Flexeril, that's the only way they'll leave your ED, fine. But they don't really work. It's not great. Great, Gary. He's added a couple more red flags. For your elderly or your osteoporosis, even a little bump onto the bum, you can get a screening X-ray. If they're in any trauma that you think is significant, the imaging that they usually get is CT. And if you find any focal neurologic findings, usually we do a neuro consult because it's very hard to get an MRI straight from the ED, or you'll do both. I mean, if it's serious enough, you would call neuro and then be like, hey, can we schedule the MRI or admit for that? So Gary said back procedures, yep, injection, sure, and anticoagulant leaves. So that's it for back pain.
Okay, so now talking about headaches. I mentioned at the beginning that I really like having at least a couple of diagnoses that as I walk into the room, I want to make sure that they don't have. So those are the 3 on the left that I've called killer headaches. And just talking about them briefly, because you'll spend a lot of time thinking about at least these 3, if not all of the diagnoses here, whenever you see a patient with a headache. The first one is just a subarachnoid hemorrhage, right? So classically, you think it's sudden onset. You want to know exactly when it started. And then you want to know how the headache is compared to previous headaches that the patient's had before. And then, of course, you really want to do a really thorough neuro exam just to make sure that they don't have any obvious neurologic deficits. And that definitely, for me, always includes just walking the patient, just trying to see how they do in that regard. And I'll go into the management in my next slide. And then in terms of meningitis, classically, you think fever, neck stiffness, altered mental status. The one exam finding other than kind of the typical neurologic exam that I do for these patients is called jolt accentuation, which I apparently can't pronounce. But basically, it's where you have the patient look left and right really quickly. And if the patient is like, wow, my headache got worse because I moved my head, then that's what we call a positive jolt accentuation test. If it's negative, they always say it's like 100% sensitive. So take that with what you will. But that's just one extra exam finding that I always like to do. And then meningitis, I won't go into this in detail, but just always think heavily about starting antibiotics early, even before your imaging and diagnostic tests. So thinking about what antibiotics penetrate the brain. And then also you have to think about the age category of these patients and whether or not you want to add ampicillin, and then also whether or not you want to add steroids or antivirals like acyclovir. And then another key history question for meningitis is if they have HIV and what their last CD4 count is. And kind of questions outside of that, we can go into in a separate session. And then the last killer headache that I think has gotten a lot more popular press since COVID started are venous sinus thromboses, which the typical, or the one patient that I've seen with this basically had a headache and then they seized and then they stroked out and then they died. So this is a pretty serious but relatively rare diagnosis. Other than the typical headache physical exam, I actually like walking into the room of some of these patients with an ultrasound and just looking for papilledema of the eye. Another thing that we can talk about outside of this, but I think that's a pretty useful thing just to weigh suspicion, and it's a really quick diagnostic test from my perspective. And then going into the real bad / not as bad as the killer headaches, we have masses. We have the pseudotumor cerebris. temporal arteritis, which the key thing is, do they have tenderness where the temporal artery is? And do they have any sort of vision loss? Acute glaucoma, I think I sometimes include in killer headaches, especially in the elderly, because acute glaucoma to me in an elderly patient can literally present as anything. I've had a belly pain patient, like Gary mentioned, a belly pain patient that actually had acute glaucoma. It's a little strange, but I've seen it happen. And then cervical dissection. So we're definitely still looking for these neurodeficits. And then carbon monoxide poisoning, I think, is more relevant to practices kind of in the north or wherever it's cold. So I would always think about it. And then that's where I think social history is really important. Like, are other people in the family also having headaches? Are they having a syncopal episode? Things like that. And then I always include others / treatment, just because when we talk about headaches, we're worried about the killer headaches, but we always want to, treat the pain itself. So in my mind, I always think, okay, well, I'll give fluids, I'll give Reglan, I'll give Benadryl. Should I give Toradol? And then kind of my adjuncts to that are, am I going to give magnesium and things like that? Those are kind of my first lines. So that's what I would think of first. And then we kind of go from there. Of course, kind of into that we always have the traumatic patient. So that's kind of separate from these types of headaches that I'm talking about today. Obviously would include subarachnoid hemorrhage, but we have a broader differential that includes fractures, et cetera. And then lastly, primary headaches, which I won't go into a whole lot because we talk about, or at least when I was a med student, I talked about it a lot. So just know that there are just some primary headache syndromes. It's not really something that we in the emergency room can treat other than symptomatically. And I would focus on these killer headaches. Next slide. So I also mentioned at the beginning that as I walk out of the room, I'm like, okay, what do I need to order next? And what's my disposition? And also, of course, treating the pain. We already talked about treating the headache itself, but really, I want to walk out of every room after having done whatever exam and whatever history taking that I did, knowing, is this patient going to get a CT? And do I have to consider, or am I going to be doing an LP for this patient? So I won't go into the heavy details about this, but basically, if I'm considering a subarachnoid hemorrhage and it's within 6 hours of the headache event, I'm getting the CT as fast as I can. If it's outside of 6 hours, then I'm going to need to get the CT, but I'm also thinking about an LP, and this is for a subarachnoid hemorrhage. And then, of course, for meningitis, we're thinking a CT before LP. And then the key here is to get the antibiotics on early. Just get them on as early as you can. Other than that, when it goes to kind of the real bad / not so bad headaches, then I'm going to look at the clinical picture and from there decide in terms of management, am I going to get CAT scans, et cetera. And I already talked about treating headaches. So I see one question here, why CT before LP for meningitis? I have a habit of getting the CT beforehand, especially if they've never had a CAT scan in the past, just to make sure that I can do it and they don't have any signs of elevated intracranial pressure. Exactly, Gary responded to that. Okay, we'll transition over to Gary now for stroke.
All right, so stroke's another one of those high yield, high risk diagnoses. You consider that definition for stroke obviously is a loss of blood flow causing loss of neurologic functions. Big things you should worry about. Next to the differential diagnosis, you kind of go down two pathways. Is it ischemic or is it hemorrhagic? Ischemic meaning, is it a blocked? Is it so like a blocked artery or lack of blood flow to airway, or is it hemorrhagic where the patient is literally just losing blood flow and that's why they're not, that would have lose neurologic function. For strokes, timing is everything. You really gotta, so 0 to 4.5 hours. So these are the time frames that you should know going forward. So 0 to 4.5 hours, that's your TPA window. 4.5, 24 hours, that's your possible thrombectomy window. And greater than 24 hours is tough shit. Well, hopefully we have to work it out and you have to try to admit them for further stroke workup, but there's nothing acutely that you need to work that you can do for them, unfortunately. Locations, everything again here. Locations can kind of, your symptoms can help you guide you to show you where your location of the stroke is. You probably, if you're going to med school, you probably learned to remember opposite side of the symptoms. So you're having a right side of stroke, you're probably gonna have left side deficits of the upper and lower extremities and vice versa. And also, when you think of posterior strokes, like the bane of every EM physician is vertigo. If anyone says they are dizzy, you need to make sure that they mean that they are lightheaded or if they feel like they have vertigo, because that's a huge difference that could be and that can be easily missed. But vertigo is a huge thing for posterior strokes, especially if it's kind of happened all of a sudden. You have no they distinctly remember what happened. That's a very big thing for posterior strokes. Also, like other symptoms such as vision loss or visual acuity, other things. Those are problems with for posterior strokes as well. And yeah, dizziness at rest, not great. Dizziness exerted with exertion, probably a little bit better, but you have to really delineate, you have to really be certain that it's only with exertion. The thing that you can use, everyone should download MD Calc on their phone, has all the big scores and everything on it. The NIHSS is something that we use a lot to help when we talk to neurologists. Not really great for per se for actual clinical stuff, but it just helps them. It's helpful to speak to them about it and kind of helps them determine when to do TPA or not. But you should be aware it is skewed towards ACA and MCA strokes. So you have a posterior circulation stroke, really not much on that except for the dysmetria testing. But again, you should always consider posterior strokes in your differential as well. Workup CT head without and CT head and neck with contrast. You're basically looking for acute hemorrhage and large vessel occlusions. You can never see strokes with CT heads unless you're well outside the window, in which case you will see signs of a subacute stroke, which means that they can't get anything done, or unless it's super early and you see certain specific signs that you'll see these things in your reading, but there's certain specific signs you can't say it's not a CT head. But generally, you're getting these scans basically mainly to rule out hemorrhage and to rule out large vessel occlusions to make sure they're candidates for TPA or thrombectomy. Also looking for other causes, aortic dissections. Someone who goes to a chiropractor and they're like, oh, my neck hurts and now I can't feel shit. And yeah, they probably have a dissection. And also the other causes for neuro stuff, look for infections. Infections cause some neuro symptoms, but don't ever have neurology tell you that the UTI is causing a person's stroke. Always yes, you should be under differential and yes, you should always treat it, but if that's a cause, but you should always consider stroke too. If you then generally think that the patient's having a stroke, you have to be an advocate for the patient. Don't listen to what your consultants say. Acute stroke, again, if they're in a window of 0 to 4.5 hours, consider TPA, TNK, whatever your institution uses. If not, then if there is a large vessel occlusion, they're probably a candidate for thrombectomy, and that's something that you should work with neurology and neurosurgery and touch base with them for. And these are also, you should always know the contraindications for TPA. Don't have your neurologist do everything for you, because when you're in a community like I am, you are the one making decisions of all this, and you have to be the one to know all these questions and know the answers to them. So these are just some quick things like prior bleeds, prior strokes, prior trauma in the past 3 months. These are all things you should consider when we talk about the risks and the benefits. Dispo, admit for stroke workup, echo, MRI, med management, and TAA, transient ischemic attack. Again, it's transient loss, they might come back normal. Most of them, you admit these people for stroke workups. However, some people, if they're younger, you can always talk about shared decision making, but that's probably something that you'll probably have to discuss with your attending about. But sometimes you can do that as well for younger patients. So.
Great. So before I talk about agitated patients, I just wanted to mention that because of time, we're going to skip over the break. And since we're at home, just ask that and encourage y'all to take a bathroom break, go get some water, get some coffee, whatever you all need. We're going to continue talking, and just know that all of this is going to be recorded, so you guys can review it at 2x speed or whatever you guys do. So the agitated patient, I think is worthwhile for any physician to know, but in the emergency room specifically, we often have patients brought in by EMS or the police department, or really just anywhere off the street, and they're just very agitated. And I'm going to talk about kind of verbal de-escalation and then different types of restraints. But I encourage all of you guys to have your own approach to how to verbally de-escalate a patient, because I think overall that's the most important thing. It's very easy to just chemically and physically restrain someone, but I would encourage y'all to try to avoid that if possible. So first, in terms of verbal de-escalation, this is a basic mnemonic that I use a lot whenever I see an agitated patient. So really, the first thing is to decide, is this a person who I can even try to verbally de-escalate? If they're like actively attacking one of the nurses or yourself, like this is not a position where you're going to talk about verbal de-escalation. If you are going down the conversation of verbal de-escalation, the second step before even talking to the patient is just to ensure the safety of yourself, the safety of the patient, and then the safety of the team that you're working with, whether that's the security guards or the nursing staff or the techs that are in the room itself. Afterwards, next is forming a relationship. So introduce yourself, ask them what their name is, how would they like to be called, and then just kind of try at least in a couple of sentences to get an understanding of why they think they're there. And then also explain your role, okay? And I think really the point is understanding what their interests are and then working with them and kind of developing that collaborative relationship. Afterwards, really it's, can I have them take medication to calm down by mouth? Will they calm down by themselves, or am I going to have to do something that I try not to do? And then that conversation really is just about setting limits and then deciding and pulling the trigger to do physical or chemical restraints. So first off, physical restraints, I hate them. I think of them as a bridge to chemical restraints, and then I take them off altogether. And basically, if the patient's being violent and actively attacking or threatening someone, then I'll ask the security officers to put on physical restraints so that we can give chemical restraints. And then about 15 to 20 minutes after giving the chemical restraints, I'm going to try to take off these physical restraints. Next slide. So in terms of chemical restraints, there's a lot of press about droperidol. So that's something that I would consider. And then there's also Haldol, and then people talk about Ativan, and then also ketamine itself. A lot of these patients, you have to think about what their access is. So most of them have no IV access, or probably they've lost IV access. So if they're willing to take PO medication, so by mouth, I typically try to do a second generation antipsychotic, which has a longer onset of action, but overall is safer for the patients. If they're very agitated and we need to give something 5 minutes ago, then we'll just go the IM route, either Haldol or droperidol. And I usually just do 5 milligrams for either one. And then I'll plus or minus add 2 milligrams of IM Ativan. And just one last note is that for any of y'all who are interested or even nervous about the agitated patient, look up Project Beta just on Google or something. And that's a lot of really helpful resources about how to manage the agitated patient. Next slide. And this is Gary now. Gary, are you on?
All right, sorry about that. So sorry with the resuscitations here. Whenever you guys have a recess happening, just get prep. You'll probably get a rundown from the EMS, or at least a call from EMS saying, hey, like this is coming in. Just get your stuff ready. While you have your airway stuff ready, your meds ready, your interventions ready, things that you know that you're going to need to help with the patient. Know your teams and your roles. it's hard, especially in the beginning, like know your nurses, know your techs, know who's gonna do what, know your interns, or I guess if you're senior, like know what you're gonna be doing procedures and know what you're gonna be doing. And have your plans ready for the medical resusces. I've had plan A, B, and C, like to have stuff ready for like their hyperkalemia, have stuff ready for bradycardia, tachycardia, stuff like that, and have your backups ready. Like like if DILT doesn't work, do you have do you have your AMA ready? If the patient doesn't respond to fluids, do you have your pressors ready? Do you have your scalpel? Do you have your bougie? Do you have stuff ready for an airway if it happens? So just know you have your backups ready as well. Once EMS gets there, make sure you get EMS story. EMS provides you with a lot of information that you might not be able to get from the patient, because the patient might be an extremis or might not be able to tell you exactly what's going on, but the EMS can tell you a lot about their interventions and stuff to do. So always take time to listen to what they say. Position yourself. I always like to put myself the foot in the bed. That way you kind of get an overall picture of exactly what's going on. You get to see like who's doing what. You can kind of direct things going on. Ask interns if it's your patient, like make sure you claim it as a patient for yourself. If your senior is one running the resus and you're doing the procedures, make sure that you have your procedure stuff ready. Like you're doing airway, have your airway stuff ready, have your line stuff ready. Don't hesitate, just have it done. And if you're a med student, just ask how you can help before it comes in. It is very hard to get to ask when they're in the middle of resuscitating a patient, get ready to help with chest compressions, etc. Again, like what you see, smell, hear when the patient comes in. And ABCs always do airway, breathing, circulation, but don't jump directly to do one thing right away. Rather, think about what you could do to help the patient. Like if a patient is bradycardic, but they might need an airway, like, don't jump to the airway, because it's more important that you fix the patient's bradycardia, because that's what's going to kill them first rather than the airway. So always try to consider what you could do for the patient rather than jumping to do a procedure, because your first gut reaction would be to try to do something because you're doing something rather than thinking through the patient's case. Perform your interventions. Do what you're doing. Like whatever you're doing, think about what you're doing. Did the DILT work? Did the adenosine work? You want to try to reassess the patient and reassess how it works or not. Because if it doesn't work, then just we have to go back, start thinking about what you're doing, see what it works or not. And then once you leave the room, remember who your sick patients are, because you're gonna have to go back to checking them over and over again. And obviously, if your disciplines are pretty straightforward, generally sick patients will always be admitted, so it's really not too much hard discipline there. In terms of asking the code status, yeah, definitely important to see if the EMS knows their code status, because especially a lot of these patients coming from stiff and everything, sometimes they'll have code statuses set up already, like DNR, DNI, and then if they are, you should definitely talk to the family about that. Otherwise, if you're not sure, I would definitely say I'd err on the side of doing more than doing less, because you can always stop doing interventions, but it's hard to bring someone back once they're dead. So especially if you're not sure. So that's my word of advice there.
All right, so now we're moving on to the trauma assessment. Like Gary said, the ABCs are important. And as EM physicians, we love ABCs, like Alma loves talking about the ABCs. And so with your trauma assessment, you have your primary assessment and your secondary assessment. So your primary assessment really begins as the patient is rolling into your resuscitation bay. Whenever a patient rolls in, well, EMS is bringing them in. I'm already looking at the patient. What is their GCS? Are they, able to breathe? Are they, is there gurgling sound coming from their airway? Do they have such a bad burn that on their face that you anticipate that it'd be a very challenging intubation? So as EMS is giving a report, I'm already kind of assessing the patient, starting with the, airway, breathing, and then circulation. So once we have the patient transferred over to the stretcher, the person who's doing the primary and secondary assessment is usually, the intern, second year resident, or if you're doing a sub-I, it could actually be you. And there should also be a resident who is actually running the trauma as well. So as you're going through your primary, it's really important to call out your findings. So, with airway, if I'm talking with the patient and the patient has clear phonation and I'm not, and the airway, I don't think there will be a compromise, I just shout out, airway is intact. And then I move on to the thorax. area. I'm looking to see if, there's any signs of trauma. Is there flailed chest? Am I hearing breath sounds that are equal on both sides? If there isn't, breath sounds on one side, this is a great time to, brand the ultrasound, take a look and assess for lung sliding. If there isn't lung sliding and the patient's also hypoxic, you needle decompress and then you put in a chest tube. And then so kind of, assessing like the thorax, if everything is normal, I call out bilateral breath sounds, like no pain on palpation of the chest. And then while I'm kind of assessing the chest in the back of my mind, like Gary said, you're kind of assessing all of these three kind of simultaneously. So with circulation, there are 5 places I like to say that a patient can bleed out into. It's the thorax, it's the abdomen, pelvis, thighs, and the floor. And so essentially, even while I'm like assessing for breath sounds, I'm thinking, if I'm hearing diminished sounds, do they have like a hemopneumothorax? For the abdomen, if it's rigid, or do they have hemoperitoneum from, a spleen laceration? And, of course, the ultrasound that's in the room that's also going to be doing the FAST along the way will be really helpful to answer these questions. And when you get to the pelvis, it's important to apply lateral pressure instead of like trying to assess whether it's stable by rocking it. Really just apply kind of like a firm pressure laterally, because if someone does have an open book fracture, by kind of rocking the pelvis to assess stability, you might actually worsen the injury. For a patient who does have an, unstable pelvis, then at this point, I would tell my team, someone like, you would delegate this task out to someone, employ close loop communication, and be like, hey, Joe, can you put the pelvic binder on this patient? And then the next step from there, I like to, palpate the thighs and then move on to the upper and lower extremities, assessing for pulse to see if there is perfusion. Let's say, you don't feel a DP pulse in one leg and there's a strong DP pulse on the other, and the patient was in a motor vehicle collision where they dislocated their knee joint, then at that point, you need to address like the pulse deficit by, reducing the knee dislocation. And so, let's say your patient's pretty much stable in terms of airway, breathing, circulation. And through all of this, you're also, looking at the vital signs, looking at their blood pressure, looking at their heart rate, looking at their pulse oximetry and tidal and things like that. If, airway, breathing, circulation is all intact, then you move on to your secondary. And so for my secondary, usually I like to then make my way up to the head of the bed, look for any, trauma to the head, look at the pupils, look for septal hematoma in the nares, look for blood in the oral pharynx, ensure that, they don't have any blood behind the ears, as well as like, at that point, you can also roll the patient over and look for C-spine, TL spine, or paraspinal muscle tenderness. You're assessing for step-offs, and then you're also checking rectal tone. If, for instance, like during any part of that secondary assessment, the vital signs change, or there's a change in your patient condition, it's always super important to then start again with your airway, breathing, circulation to ensure that that there aren't any new presenting injuries that is causing this. And so some of the most helpful things that you can do as a sub-I or an intern when you're just starting out and you're not the person doing the primary secondary assessment is that you can, definitely bring the ultrasound in the trauma room. It's like super helpful. You can, help get set up for procedures. Like being prepared is key in emergency medicine. Sometimes being the person simply at the closest side of where a chest tube is needed, like you will be the person doing that chest tube. So just be prepared. And that's it for the trauma assessment.
Okay, so next we'll transition to talking about a couple of different airway maneuvers. So first I'll talk about non-invasive positive pressure ventilation, and then Max will talk about intubation. So I'm mostly going to focus on BiPAP because I just prefer that versus pretty much ever doing CPAP. And really when I see the patient, I'm thinking kind of the airway and breathing part of the initial algorithm. So my question to myself is, how fast are they breathing? Do they have breath sounds? Are they hypoxic? And then do I suspect that they're retaining carbon dioxide? So really it's, are they hypoxic? Are they hypercapnic? And then those are the two reasons that I'll start BiPAP. If I think this is some sort of like COPD, CHF exacerbation, and I think they're just retaining, it's really important to kind of understand what their respiratory rate is beforehand, and to also get a VBG or an ABG before you actually start BiPAP. And then when I decide to start BiPAP, I'm going to tell the patient, hey, like, this is going to feel like you're driving 60 miles per hour on a motorcycle without a helmet and the wind is blowing in your face. It is uncomfortable, but I'm doing this because it's necessary to help you breathe. I always start off any sort of BiPAP conversation with the patient with that, because it is uncomfortable and most people don't like it. And then the other thing I think of is this patient altered? So if I don't think that they're going to tolerate BiPAP, or if I think that if they throw up, they're not going to be able to take off the machine itself, then I'm going to think again about BiPAP and heavily consider just intubating them to protect their airway. That's pretty much my only relative contraindication to BiPAP itself. And then from a hypoxia standpoint, really it's all about adding positive pressure to recruit more alveoli for oxygenation, and also to basically help their work of breathing. So basically you're pushing air into their lungs so that hopefully they don't tire out from all the extra breathing they're doing. And then, so now I've put on the BiPAP machine, or I've called the respiratory therapist and they're putting on the BiPAP machine after I've talked to them. And I tell the respiratory therapist that I want this inspiratory pressure, this expiratory pressure, and the typical ones are like 12/5 or 10/5, something like that. One of the important numbers in this isn't just those two numbers, but it's the difference between them. It's the driving pressure, right? So that's the inspiratory pressure minus the expiratory pressure. And I think of that as a way to really help control my tidal volume. So the reason I'm focused on tidal volume is basically what controls, or I'm putting on BiPAP because I want to control how fast they breathe, what I call their minute ventilation. And then what controls their minute ventilation is one, their tachypnea, so their respiratory rate, and then second, their tidal volume. So if someone's breathing really fast, if I increase the amount of tidal volume that they're getting, that means they're not going to have to breathe as fast, because the increase in tidal volume leads to a decrease in the respiratory rate to get the same amount of minute ventilation. So in this kind of basic example right over here, you can see just in red what the tidal volume of a patient is, and then in orange what the minute ventilation is. I'm only bringing this up because I want you guys to think every time you put on a BiPAP machine, I want you to look at the screen, know the numbers you're looking at, and then know what your goal is. So if you're treating a hypercapnic patient, you want to blow off oxygen. You want to blow off carbon dioxide. So the number in orange, you want to increase. You want to get it to more than definitely this number here, which is basically 4 liters per minute. You want to bring it at least to above 6 to 7 liters per minute. Which is kind of for our typical selves, kind of people without BiPAP, that's our typical minute ventilation of 6 to 7 liters per minute. Okay, so whenever you put on a BiPAP machine, look at those numbers, and then in real time, working with the respiratory therapist, you can change the inspiratory and expiratory pressure to increase the tidal volume. And then after you change those, reassess. And then the second and last takeaway before we talk about intubation is this isn't mechanical ventilation. Only think of BiPAP as a bridge to something else. You want to either use it until you don't need it anymore and you're treating something. So if it's a pneumonia patient, you're treating the pneumonia until you can resolve their respiratory issue, and then you're off BiPAP. Or your option is BiPAP to intubation, in which case you're trying BiPAP, and then when they're failing it, then you have to intubate the patient. Never think of BiPAP as a treatment. It's a bridge to something else. You have to go somewhere else from there. Okay, with that, I'll transfer to Max.
All right, so intubation for 5 or so minutes is going to be very tough. So I'm going to be essentially just treat this as a 5-minute talk on just dropping a lot of terms so that next time you hear about this in a more like slow and more digestible fashion, you'll kind of learn to recognize those terms and be able to digest them more in a more efficient way. And I'm going to really talk about the actual physical act of placing a tube between the vocal cords, because I feel like that's a very small part of the intubation process and something that's actually much better taught in like a sim lab or in real life by watching intubations. So in terms of when to intubate, David already kind of alluded to a lot of this. So classically, I think people like to talk about 4 big criteria. So when patients cannot ventilate by themselves, or cannot blow off carbon dioxide enough, if they cannot oxygenate enough by themselves, and then airway protection, like the massive GI bleed that I talked about, and then anticipated clinical course. That usually means like the airway is okay right now, but it is going to get worse. So a classic example would be like an angioedema patient who is breathing, but you think it's going to get, the swelling is going to get worse and they won't be breathing very soon. Setup is everything, and this is kind of what I'm going to be talking about most. So I like to use SoapMe. I think this is like anesthesia kind of developed mnemonic. So suction ×2. Make sure it is hooked up and working before you intubate anyone. Make sure you have oxygen, nasal cannula for while you're actually intubating, and then bag valve mask to bag the patient in case you cannot get the tube the first time, or right before you intubate too, after you paralyze the patient. Airway adjuncts and equipment, obviously you need them. P for positioning is what I use. There are a couple different variations of this mnemonic. And then medications, and make sure the patient is hooked up to monitor. And then as part of the monitor, you should also have end-tidal when available for accurate monitoring. All right, so next, airway equipment wise. So whenever you're selecting your equipment, I have it in red up here. So you're thinking about the patient characteristics and clinical situation. You should have an intubation plan in mind evolving so that you can pull out the appropriate backup equipment and have them ready to go. There are many different versions of like the difficult airway algorithm and things like that online that you can look up, but essentially a lot of them, you can try something once, and then if that doesn't fail and you want to go in for the second time, something needs to change. Either the laryngoscope you're using, the tube size that you're using, the positioning, or the operator. One of these things have to change, otherwise there's no point in trying again. So some of these equipments, the laryngoscope refers to the actual blade you're using. These are largely divided into VLs and DLs. VL is video laryngoscopy, DL is direct laryngoscopy. People get confused because some people use the wrong terminology. A lot of people say using a Mac blade, which is the curved one, the first picture here, as DL, but this is wrong. The Mac is the actual shape of the blade. Direct is if you don't have a video hooked up to it. If you're using something that has a video screen, by definition, it is VL. If you use a Mac blade with the gyroscope, you're using a VL with the Mac blade, or a standard geometry blade, sometimes it's called. And then tube you need to grab, obviously. I always like to grab an extra small one in case you go in there and you feel like the tube is too big to go in. And then you need to pick the stylets. There's the rigid stylet, which goes with hyperangulated blade, which is the first one there. And then a flexible stylet, which goes in with the standard geometry or Mac blade or a Miller blade too. And typically you want this like hockey stick formation where it's straight to the cuff and then like a 30-degree bend, just like it is here. And then the bougie that everyone likes to talk about is much more flexible. It is much longer, but it's great and everyone loves it. You also need to grab a packet of lube, a 10cc syringe, because you need to make sure the cuff works, and lube up the stylet. And then some adjuncts like nasopharyngeal or pharyngeal things. I don't actually physically pull them out, only because I know exactly where they are and they're right nearby. So in real life, first thing is make the decision to intubate and make sure everyone else in the room is on the same page. And then you have to assess the patient and make sure you come up with a plan. Look up Lemon Airway assessment, but essentially it's like looking at the body habitus, how difficult you think it's going to be if they have dentures in the mouth. Pull your airway equipment. So keeping your plan in mind, pull all the airway equipment that you're going to think you're going to need, and make sure you lube up the stylet, check the tube cuff. Make sure if you are using the gyroscope, it is plugged in, turned on, and is working. Make sure the suction is set up, the supplemental O2 is hooked up, and tidal is ready for monitoring. Make sure someone is pulling the meds. Make sure someone can call the RT so that they can be hooked up to the vent after you intubate them. Position the patient, position yourself so that you also get into the right position, jump through the million wires and everything else that's going to be in the way. And nothing makes it clear to the rest of the room that you're about to intubate the patient than you standing at the head of bed with this blade in your hand, across to the rest of the room so that everyone is on the same page. Paralyze and induce the patient, so push the medications. And then you pass the tube. So in this step, you're going to take out the dentures if they're there, scissor the mouth open, insert the blade, strip the tongue, all of those things. Once the tube is in there, do not let go until the respiratory therapist takes it from you. Don't let go of that tube. You put it there. It took a lot of work to get it in there. Confirm the position, whether that's with color change in the CO2 detector, and tidal on the monitor. Someone should listen for bilateral lung sounds. It could be you, it could be someone else if you're holding onto the tube. And then chest x-ray. And then don't forget about post-intubation medications. Make sure the patient will be comfortable. If they need to be paralyzed, make sure that's also on board as well. And then you have to put in the initial vent settings, but make sure you kind of recheck the, reassess the patient and tweak the vent settings so that you are actually treating whatever other underlying disease process is going on. So the things that are in yellow are if a patient is really, really sick, these are kind of the minimum steps that I would do. Obviously, you need to make the decision to intubate, quickly assess the patient, quickly come up with the plan, pull all the airway equipment. The rest of the stuff, I feel like if the patient is very sick and I don't have time to do those things, I can ask someone to help me. Someone else can help me have suction, O2, and tidal ready. Pharmacists can help the medication to be by bedside so we can push them. Someone else can call the RT. Someone else can also help position the patient. I might not care too much about my position if it's like a code and chest compression takes precedence. And then pass the tube, make sure you confirm that tube, and then the post-intubation medications cannot be bypassed either. So if you, not all of these are done for all the patients. There was a lot of information about intubation. If you take anything away from that talk, just preparation is everything. So you will hear that talk many, many times, and just be prepared for everything. Oh, it's me again. Okay, so talking to consults. All right, so first thing is you have to introduce yourself. They have no idea who they called. They just called a number. And they also need to figure out how they can potentially find you if they have more questions later. give them an opening line or a hook. This is your like one line of a patient where you can mention or hint at the question. You're trying to sell the story, remember that. Get the consultant hooked on early so they actually pay attention to what you're saying. So like I have an 80-year-old female with a comminuted hip fracture for an orthopedic surgeon, or like I have a 37-year-old who was in a cardiac arrest post-ROSC if you're calling the NICU for admission. Give them, ask them if they want an MRN or the room number so they can locate the patient. It's much easier for them to follow the story if they are actually reviewing the chart at the same time. I usually give them the MRN or the room number and then give them a moment to pull up the chart and say like, let me know when you're ready, because some people can't like listen to the story while typing in the MR and looking up the patient. Give them a focused H&P. Again, you're selling the story, give them what's relevant, obviously depending on the context, and be consistent. Yeah. And then the clinical course, what I've done so far for the patient and why they need admission or whatever else exactly. So as an example, so going back to my GI bleed talk, I would do, hi, this is Maxio in the ED. My opening line would be, I have a 38-year-old male that requires emergent scope for massive upper GI bleed. So I'd be calling like a GI consult at this point. Would you like the MRN or the room number? Give them a pause, and if they say they're ready, I say, so he has history of alcohol cirrhosis with known esophageal varices, came in with 4 times large hematemesis since last night, soft blood pressures on arrival to 90s over 60s, tachy to 110s, has been protecting airway though. So initial hemoglobin was 7, down from 9 that we have on EPIC 2 weeks ago. I've given him 1 liter normal saline to start with. We've given him 2 uncross-matched RBCs, given him 80 of IV protonics, Rocephin, octreotide bolus and drip, as well as Sofran. Vitals are unchanged with another episode of hematemesis just now, so I think he needs an urgent scope. I've already talked to MICU. And then, so additional tips. Know your patient. If you don't really know what you're talking about, the person on the other side of the phone is probably going to think, how do you even know if you're calling the correct consultant? And they'd probably be right to question you. But there are instances where you just don't know much, and just make sure you establish that up front. I've literally had to call consults on patients I was walking by and then they coded. So I had to like call cardiology and just try to sell the story somehow. Just say, I apologize, I don't know anything about this patient. They're actively coding and I was walking by. This is what I have. Mention how sick and not sick they are early on. Stable, unstable, whether it's like, this is an emergent consult to, you don't actually need to see this patient. I just wanted to make sure they get close follow-up. This puts all the information in the context. And then make sure you tailor the story. Like I said, you're trying to sell it to the consultant. If the patient has been evaluated or had a procedure performed by the service before, drop that attending's name. This is a 60-year-old male who just had a cholecystectomy performed by Dr. whatever surgeon 4 days ago and now returning for post-op fever. That gets them hooked. It hopefully sparks like a sense of ownership in them. In some instances, let them know why they are being consulted. Mention other services that are also involved. So in like a polytrauma situation, let them know who else has been consulted so that they don't make unnecessary phone calls and waste their time. Ask if they want anything else cooking. So like labs, additional imaging, sometimes they might want within reason. You can put them in before they see the patient. And last of all, these kind of 2 last points go hand in hand. Be respectful, knowing that not everyone will be respectful towards you. People don't understand your work schedule, your work environment, how many other sick patients you have. But at the same time, you don't know theirs either. They are going to be your coworkers for many years. Your paths will cross many times in residency. So just remain respectful. But at the same time, just know that you and your team who is evaluating the patient made a clinical decision that the consult is indicated. They are taking that phone call because it is their job to do so. So kind of always bring it back to the patient, advocate for the patient, and make sure the right people are called and right services are evaluating the patient. That's it.
Thank you, Max. And so we're just nearing the end of the session before our breakout rooms. So I wanted to highlight a couple of them awesome emergency medicine organizations and opportunities that are available. So, again, congrats on picking the best specialty. And for folks considering emergency medicine is such an awesome field. So the main organizations to help jumpstart your careers as emergency medicine physicians include Society for Academic Emergency Medicine, RAMS. You also have EMRA, which is the Emergency Medicine Residents Association. And then you have RSA, which is the Resident and Student Association. They're affiliated with American Academy of Emergency Medicine. And because of my involvement with RAMS, I really wanted to highlight some of the resources that we have available. So if you're even considering about doing a fellowship after having matched into emergency medicine, SAEM RAMS has these awesome roadmaps that really guide you of what you should be expected to know and kind of do starting from your intern year to when you match into that fellowship. We also have amazing webinars that are geared towards medical students and residents on at least once a month. In July, we will be inviting folks from Cordover to actually talk about preference signaling, which will be new in the upcoming year. So you definitely, want to stay tuned and come in for that. We also have a lot of awesome podcasts and our magazine, which we love having residents and medical students contribute to as well. And then the awesome thing about RAMS is that you get to work with attendings directly in the academies, committees, and interest groups. And so really you get this organic mentorship and sponsorship. And you get that from a whole list of awesome academies and committees and even more interest groups. And if you see something that you're interested in that isn't an interest group or academy or committee, please let us know. I'm sure, one of the awesome things about emergency medicine is everyone's so multifaceted and have so many interests in that, the specialty is expanding in different areas and niches that we fill. So there are constantly new interest groups as well. And one of the great things that David actually mentioned, and I actually met David back in Orlando at SAEM 17, was through this medical student ambassador program. You are the main volunteers for the conference. You get one-on-one mentorship from one of the faculty members. And then these past couple of years, we actually started travel scholarships as well for students. And truly, it's a life-changing experience. You kind of get to experience that tight-knit and incredible kind of emergency medicine community. And it really has made a positive impact in my career trajectory. And last but not least, if you're interested in being a voice for residents and medical students on important topics such as, workforce discussions, please consider running for the SAEM RAMS board. We are invited to all EM organization discussions. And so, over the past year, we've been in every other week, at these workforce discussions. As a RAMS board, you get leadership development, you get mentorship, you get, and as well, a definite perk is that you get free travel and housing to SAEM and ASAP as well, which is awesome. And so now I think it's time for breakout rooms. I will open them up. And so as you'll see, there will be 2 breakout rooms based on kind of your training level. Please join either the sub-I one or the intern one, and then we'll have a couple of speakers there to greet you and answer your questions. And if we don't reconvene after the breakout sessions, I just wanted to thank everybody at APAMSA and the board for organizing, and also our panelists for, putting on this great EM boot camp. I think before we do separate out, I am so happy to put in my email in the chat. So if you have any questions about emergency medicine, about, the match, about RAMS, please shoot me an email. And now I'm going to open up the breakout session, and we we'll get started. All right, so the rooms should be available for you to select which one you want to go into. So feel free to pick one and then we'll be whisked away.